feel free to interrupt and raise your hand and ask questions. Okay, so what is a normal image? A normal IVUS image is intimate. A normal IVUS, all right. It's intima, media, and adventitia. Okay, it's 3 layers, nothing else. The media that you are born with is about 200 microns. With increasing atherosclerosis, the media gets thinner. So if you see an image like this, where you think that this may be media, it is not media. It represents a combination of media plus attenuation of the ultrasound signal going through plaque. That's really important. And the reason that's important is because plaque is not this. Plaque is this, minus the media, which is, as I said, only 200 microns. And so when you calculate plaque burden, it's the ratio of this to the vessel, not the ratio of this to the vessel, okay? Let's talk a little bit about what happens outside the vessel. So here are several examples of veins. This is a vein. This is a vein. This is a vein. And this is a vein. How do you differentiate a vein from a branch? Well, the veins don't connect with the main lumen. So you have to look up and down. It's very simple. You may not be able to do it on a single cross section, but you scan up and down the vessel. So here's an example. These are veins. And these. They don't connect with the main vessel. Okay? And here's an example of vasovasorum. These things are vasovasorum. You can see them here. Okay? And then what is this? It's coming in and out. This thing here. No, it's pericardium. Okay? And so here are several other examples of pericardium. Here, here, and here. Okay? This is a muscle bridge. This is a muscle bridge. This is a muscle bridge. It hugs the adventitia. And this is a muscle bridge. Sorry?
Pericardium versus the muscle bridge. Are there distinguishing factors that make one easier to identify than the other?
Okay, so remember, what is the pericardium made out of? Fibrous tissue. It's bright. It's bright. What is a muscle bridge? It's muscle. It's not bright. And depending on how much pericardial fluid is there, this distance can sometimes get kind of large. It doesn't mean that there's a huge amount of fluid, because remember, this is only a millimeter. Okay? So the big thing is pericardium is fibrotic, and it doesn't hug the vessel. Okay? No. Sorry? No. The only time you can confuse a vein is in the right coronary artery, where the vein bridges over, But muscle bridges don't happen in the right coronary artery. They happen in the LAD mostly. Yes, it's moving. It's constantly moving. This thing is moving up and down. Up. Let's see if I can get this to move. No, I don't have it here. I thought I had one. Oh, here it is. See, this is the pericardium. It's moving. It's constantly moving. And it's not moving in conjunction with the vessel. It's moving independently. Okay, so three examples of pericardium. This is an example of a side branch connecting with the main vessel. And these are muscle bridges. Now, why is a muscle bridge important? You don't want to extend a stent into the muscle bridge because the stent will fail. Okay? Calcium. Calcium is bright, brighter than the adventitia with shadowing. These are a whole series of IVUS and OCT images collected over the last 30 years from many different companies. And they all have the same thing. Bright with shadowing. Okay? Bright with shadowing. Now, the most sensitive feature is if the image is bright. The most specific is reverberation. So this is reverberation here and here. And another example of reverberation here, 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 and here. What's reverberation? Imagine if you're standing in front of one mirror and another one's behind you and the light's going bang, 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 bang. This is the same thing that's happening with ultrasound. It hits here, it goes back. Let me try this. It hits here and it bounces back. If it here, it bounces back. And every time it bounces back and forth, it creates another ghost image. So it's like every time I go hit and I go back, I generate an arc. Again, a second arc. Because the image is generated by the time it takes for the ultrasound to get to the structure and back to the transducer. Sorry? I'm sorry, I can only hear one at a time. Three things cause reverberations: calcium, metal, and plastic. Okay? Where do you have metal? Stent. What do you have? Plastic. Guiding catheter, and maybe a covered stent. So these are just some IVUS and OCT images. This is normal. This is lipid, sort of. This is fibrotic plaque, sort of. And this is calcium. I don't particularly like tissue characterization based on IVUS. I think there really are only a couple of tissue types that are detectable. One, of course, is calcium, which you see here. And the second is attenuated plaque, which you see here. Now, what is attenuation? What is attenuated plaque? If the ultrasound does not penetrate to the adventitia, okay, you lose the adventitia and it gets dark. And that's because the ultrasound is scattered, never gets through to come back. And so this is predictably calcium. This is predictably a fibroatheroma. Don't try to diagnose fibrotic plaque. Don't try to diagnose lipid in the absence of attenuated plaque, because the crossover of hyperechoic to hypoechoic plaque is huge and unreliable. Okay.
So hypoechoic area without an hyperechoic line means it's lipid.
No. You cannot diagnose when you have attenuated plaque, which means you don't see the adventitia. The adventitia is supposed to be here, but you don't see the adventitia, and it's hypo, which means it's less dense than the adventitia, means that it's a fibroatheroma. And the only two reliable tissue types that you detect by grayscale IVUS is calcium and fibroatheroma. Other examples of calcium, this is deep calcium, which is closer to the adventitia. This is superficial calcium with reverberations. This is concentric calcium with reverberations. This is eccentric calcium with reverberations. And this is a calcified nodule. Okay? Those are the typical features of calcium, or at least the typical descriptors of calcium. Now, we can quantify calcium based using a protractor centered on the lumen. You basically center on the lumen and you measure the angle. And that's just a very simple, crude way of measuring, of quantifying the calcium that has stood the test of time. Ultrasound cannot measure calcium thickness, period. It can measure the arc and the length, and that's it. So the answer is we don't know. For some reason, that has become a rule, but we really don't know. This is, yes? There is one study, I know, we wrote that study. It was one study in a relatively small number of patients, okay? Now, this is something that I wrote a long, long time ago, and we repeated it, and it just shows you that it's only until you get about 3 or 4 quadrants of calcium that the angiogram starts to become even close to reliable. Spotty calcium. This is a paper from 20 years ago from Japan looking at spotty calcium, and it's more common in MI and acute coronary syndrome than stable angina. Why? Because just like attenuated plaque, spotty calcium seems to be a marker for a fibroatheroma, and therefore it is seen more in unstable lesions than in stable lesions. And here's an example why this is NIRS IVUS. Obviously, IVUS is here, and we have near infrared spectroscopy here, and the lipid correlates with spotty calcium. Okay? Now, what does spotty calcium probably mean? It probably represents an intraplaque necrotic core that emptied and healed. This is, so remember we talked about attenuated plaque, we talked about calcium. You can call this hyperechoic non-calcified plaque, that it is as bright as the adventitia without shadowing. This is actually attenuation that's deep, but there's no shadowing, there's no shadowing, there's no shadowing. What does this mean? Probably means that there's fibrotic plaque, there could be some lipid. It doesn't correlate one-to-one with anything. So that's why I am very careful, and I call this hyperechoic plaque. I don't try to assign any tissue type. I do not assign plaque composition other than calcium or attenuated plaque. Now you can do that, but I won't. And then at the opposite is hypoechoic plaque. That's plaque here that's less bright than the adventitia. But again, there could be lipid, there could be thrombus, there could be fibrous tissue, there could be lots of things. And the ability to expand a lesion is not just related to the plaque composition, but it's also related to the degree of positive and negative remodeling. There are a lot of factors that go on. These are examples of attenuated plaque, and I'm going to show you, I'm showing you several of them so you see how consistent it is. It's hypoechoic, and you do not see the adventitia. It's hypoechoic, and you do not see the adventitia. It's hypoechoic, and you do not see the adventitia. Okay? Consistent findings. And it represents a fibroatheroma. Now, what is a fibroatheroma? Well, it's a high-risk plaque that can do lots of bad things. One of the bad things it can do is it then intrudes into the lumen after you stent. So this is attenuated plaque, right? And then after stenting, you've got this tissue inside. That can embolize and cause a periprocedural MI. The good thing is that it disappears over time on its own. Okay? Because it's a combination of lipid, necrotic core, thrombus, and a bunch of stuff. And over time, this just disappears. So you don't chase it. If it compromised the lumen, let's say it was actually a lot like this, okay? The way you treat it is not with a balloon. You treat it with another stent to try to capture it. Another example, this is a live demonstration case. It was, I can't remember, I think it was someplace in China. At any rate, this is a left main lesion, attenuated plaque. The operator didn't listen, shut down the vessel because of distal embolization. And as I said, this is predictive of a fibroatheroma. And you know, if you want to look at this article by Pu, one of our fellows, it was actually a very good article correlating ultrasound appearance with plaque composition histologically. Now, the next thing I want to talk about is eccentric versus concentric plaque. So look at this lesion and decide on your own angiographically if this is eccentric or concentric. So you can see by IVUS, it's eccentric. This is normal vessel, this is normal vessel. So this is totally eccentric plaque. Is this concentric or eccentric? And it's totally concentric. Here's the lumen, here's the adventitia, it's concentric. Okay? Does that matter? Probably not, unless you happen to be doing directional coronary atherectomy, which you don't have in India, only exists in Japan. And this is another old paper that we wrote. Regardless of what the angiographic appearance is, roughly 50% of the lesions look eccentric, 50% look concentric. Flip a coin, who cares? Remodeling. This is Seymour Glagoff. He was a pathologist at the University of Chicago. He wrote this in the New England Journal of Medicine in 1987, and he showed that plaque accumulates and the vessel dilates to preserve the lumen. We call it positive remodeling, Glagovian remodeling, lots of terms. And on average, it continues until you get about 40% of the vessel, and then plaque starts to intrude on the lumen. These are some examples. Why is that important? It's important because 75% of the plaque in the coronary arteries is angiographically silent. So here's a lesion in the right. Here's the lesion here, and look here. Where is C? C is right here. This is the lumen. This is the adventitia. You've got a plaque burden of 75% angiographically normal. Another example, 80% plaque burden in a segment of coronary artery that's angiographically normal. This is what determines the long-term mortality of a patient, not the lesion that you're stenting. Now, sometimes positive remodeling can overcompensate, and that causes ectasia. Ectasia is just that with plaque accumulation, the vessel actually overshoots the remodeling process. And if we look at this example here, here's a reference here, here's a reference here, but look at the overshoot. It's big. Look at the overshoot. It's big. This is on the way to becoming an aneurysm. True aneurysm, of course. And you see this not uncommonly. And then here's some examples of positive and negative remodeling. This is a lesion in the LAD. You can see at the lesion site, the EM is bigger than the proximal reference, so that's positive remodeling. And here at the ostium of the LAD just distal to the ramus, you can see that the EM is smaller than the reference, and this is negative remodeling. The vessel has an hourglass shape, okay, with modest amounts of plaque here. Almost all osteal lesions have negative remodeling. Other lesions do as well, and we're not really quite sure why, but negative remodeled lesions tend to have more calcium than non-negatively remodeled lesions. This is a true aneurysm, a couple of them. True aneurysms, well, let me back up. Pseudoaneurysms, which is the only other thing you care about, only happen after a PCI has been performed, and they represent rupture of the vessel. True aneurysms are large. This is a boy with Kawasaki's disease, much larger than the reference, and it has 3 layers. It has intima, media, and adventitia, okay? That's the characteristic of a true aneurysm. 50% larger than the proximal reference with all 3 layers intact. But in order to see that, you have to change the zoom setting of the machine so that it's not off the screen. And everybody forgets to do that. And then they say, well, is it a true aneurysm or a pseudoaneurysm? And I say, well, it's off the screen, I can't tell you. Another example of a true aneurysm, you often, when you see these true aneurysms, you'll have tight stenoses, often on both sides, and they're often calcified. So it makes it hard to treat, but there's nothing wrong with stenting across this. You know? So I'm not doing very good. Okay, plaque rupture. It's easier to see plaque rupture by OCT than by IVUS, but that doesn't mean you can't see it. And if you look at the statistics, it's about the same. The frequency of plaque rupture in IVUS studies and OCT ACS studies is about the same. So plaque rupture is a break in the fibrous cap, usually at the lateral attachment, can be central, but usually it's lateral attachment here and here, with a cavity. Cavity, cavity, okay? Very simple. You can't tell how old it is. We can only tell if it's anatomically present. The most common cause of acute coronary syndrome, although I think the frequency is probably going down as the frequency of erosions go up, and I'm not talking about India, I'm just talking about globally, because that's somewhat related to patient age and being on statins and a lot of other things. Another example of a plaque rupture, look for the lateral break and the cavity, okay? Now, this next case is sort of interesting. We have angiograms at 2 time points looking at the proximal right, here, and then here. And you can see clear evidence of a rupture angiographically. It's this. Let me see if I can draw it out. Call it an ulcer, whatever. Ulcerated plaques are plaque ruptures. It's a cute angiographic term that means plaque rupture. And you can see here is the site of rupture, and here is the cavity. They very often have calcium at the base. I'm not sure I understand why, but I know that they do. Now, there's a lot of discussion. We had discussion earlier today about what to do with plaque rupture, with STEMI patients with plaque rupture versus plaque erosions and so on. Today, based upon huge amount of randomized trial data, STEMI with plaque rupture should be stented. Now, what do you do about an erosion? We don't know, because the The real natural history data that we have available is only in small numbers of patients. This is another example of a plaque rupture, but in this case, the rupture site is filled with thrombus and is protruding out into the lumen to compromise. So plaque ruptures by themselves contribute to disease progression, but they're not necessarily bad unless they compromise the lumen. And they compromise the lumen based on two things. One, they become thrombotic. And two, you've had enough recurrence of plaque rupture at that site to have a large plaque burden so that the next plaque rupture compromises the lumen. But this is an unusual case. I don't have many of these in my collection, but you can see that the thrombus is clearly inside the cavity and extends out to compromise the lumen. Sure. Go. Absolutely. No, but this is a thrombogenic environment. Okay. Yeah, one of several things. You can put them on high-dose statins and bring them back, or you can use distal protection.
Gary, we got a minute left for the session.
Right, but I've got another 15 minutes. So
You want to go to one or two of your best slides remaining?
No, I do the next talk.
Yeah, you use both.
I use both?
Yeah.
It's a half an hour already?
Yeah.
Oh. All right, sorry. So, diagnosing erosion is best done by OCT, and it's mostly a diagnosis of exclusion. It's an acute coronary syndrome lesion with intact fibrous cap. That's what's an erosion. You can do all your sort of thing, well, this, that, and the other thing. ACS lesion with intact fibrous cap. Every so often, we will see it by IVUS. And here's an example. And if you look very closely, first of all, the plaque burden is modest, right? Maybe 40 to 50% at most. And then, what's this? And what is this? I can't see better on an actual screen than this. So thrombi are not easily diagnosed by grayscale IVUS. It's better with HD IVUS than with regular IVUS, okay? But every so often you see this. Now, if you are trying to distinguish, I was listening to the previous talk, distinguish between thrombus and blood stasis, what's the simplest thing to do? A little bit of saline, a little contrast, a little saline, it'll get rid of the blood. Another example of thrombus you can see here and here and here. The consensus document that I wrote 20 years ago said that the diagnosis of a thrombus by grayscale IVUS is presumptuous, but it's better with HD than with conventional. And so this is the first reported case of a calcified nodule before the pathologists even knew what these were. This is an elderly woman who presented with acute coronary syndrome with this in her LED. It was on a Friday. We put her on anticoagulation over the weekend and brought her back, and it hadn't changed. And we did IVUS imaging, and you can see this a calcified nodule. Remember, ultrasound doesn't penetrate calcium. So this nodule is probably this, but you only see the leading edge, okay? Now we're starting to recognize that there are probably two kinds of calcified nodules. One are eruptive with this broken surface, and the other is non-eruptive with a smooth surface and probably an intact fibrous cap, and their natural history is very different. The eruptive ones do worse, both treated medically and treated with PCI. Another calcified nodule, this in the distal left main, and you can see the calcified nodule with this jagged surface. And that's a pullback from the circumflex and the pullback from the LAD, okay? Jagged surface. That's an eruptive calcified nodule. Spontaneous coronary dissection. We had a whole talk about it, and everybody says, have to use OCT. That's bullshit. If you can't diagnose spontaneous coronary dissection with either IVUS or OCT without even thinking twice, you're in the wrong business. So here you can see the vessel collapsing, the adventitia expanding with hematoma formation. Now, I used to think that a spontaneous coronary dissection was that the media broke in half and the internal elastic lamina contracted and the external elastic lamina expanded. Not so. This is an HD IVUS image, and notice intima, media, and adventitia all collapsing. So this is actually a separation in the external elastic lamina. So that part of the external elastic lamina goes in, part of it goes out. And we see this consistently with the HD IVUS. And you can see, obviously, again, the collapse of the vessel, the adventitia outward, and there's some hematoma, and so on. The one thing that you'll see better with OCT is the entry and exit point. No. An intramural hematoma that's procedural aided is dissection to the media, not this. That's what one of the theories are. I don't think anybody really knows for sure. This is another example. This is a woman who had valve surgery years ago, was in the hospital waiting for redo valve surgery, and you can see her angiogram, and then 1 week later. And she had multivessel SCAD. Again, notice the 3 layers have collapsed. So that's a break in the adventitia or extraelastic membrane. And the pathologists say the same thing, they just never said it well. And you can see how it extends all the way back to the left main. Another example, I said these all look alike. If you can't figure this out, you're in the wrong business. So this is all an intramural hematoma from spontaneous coronary artery dissection. All right. No. But the other thing you sometimes see in here, you see this? What is this? What's this? No, that's most likely just contrast that you've injected, saline that you've injected, or the hematoma has separated into cellular and non-cellular elements. And anything that's black on an ultrasound is homogeneous in its density. And so blood is heterogeneous, saline, contrast, serum, plasma are homogeneous. Right, well, can talk forever. How to what? Web lesions. So I don't have any on here. Web lesions are recanalized thrombi, and if you had a vessel like this, you would have multiple, like Swiss cheese, lotus root, et cetera, et cetera. All right, well, I got a lot more I can talk about, but time's up.
All right, thank you so much.